Make sure to like, share, and subscribe to Decode Healthcare with Harshal. Welcome back, everyone. We're officially on part 40 of our 100-part CPC exam series. And listen, today's explainer is absolutely critical. We're tackling the CPT medicine section. This is an area where even seasoned coders, people who've been doing this for years, literally lose massive amounts of money for their clinics just because of simple bundling errors.
So, ready to crack the CPT medicine section? Up until now in our series, we've spent a lot of time hanging out in the surgery section, right? And that's super visual, very anatomy-focused. But the medicine section, you got to take off your anatomy hat and firmly put on your auditor hat. Because this section, it's a highly rule-driven beast.
Spanning from code 90281 all the way to 99607, you want to think of this section less as one giant chapter, and honestly, more like a collection of distinct little mini-systems. You've got cardiology, psychiatry, immunizations, and each one has its own strict internal logic. To actually pass the CPC exam, you can't just memorize codes here. No way. You really have to master the specific component rules and the time-based tiers for every single specialty.
Let's jump right into Rule 1, the dual code mandate.
This rule governs how we code immunizations, and it demands a strict dual coding approach. Basically, when a patient gets a vaccine, you cannot just code the vaccine liquid itself. Think of it like, taking your car to the mechanic, right? You have to bill for the labor, which is the immunization administration code for giving the physical shot, and the materials, which is the specific vaccine or toxoid product code. The exam absolutely expects to see both.
Now, here's a classic trap that auditors and the CPC exam literally love to spring on you. For patients 18 and under, you've got two paths. If the physician provides documented, face-to-face counseling with the parents, you get to use the higher-valued pediatric codes, and those are uniquely coded per vaccine component. But, and this is a huge but, if there's no counseling documented, or if the patient is 19, you must default to the standard administration codes. Actually, a good rule of thumb: never assume counseling happened just because it's a kid. If it isn't written down, it didn't happen.
Moving right along to Rule 2, the infusion coding hierarchy. Let's tackle injections and infusions. This brings us to the rule of initial code. When a patient gets multiple types of IVs during a visit, you don't just code based on chronological order. It is based on a really strict clinical priority ladder. So even if the nurse hangs a simple hydration bag first, if chemo is given, say 2 hours later, chemo steals the top spot. It's always chemo first, then therapeutic or prophylactic, with hydration sitting at the very bottom. You report only one primary initial code per encounter.
And hey, time is everything here. An initial infusion has to cover at least 16 to 90 minutes. What if the infusion finishes at 14 minutes? Well, then it's considered an IV push, not an infusion. Billing a 14-minute push as an infusion is a fast track to a denied claim, for sure. For extended infusions, you'll just reach for specific add-on codes to cover those additional hours or any concurrent medications.
All right, next up is Rule 3, the component split.
Welcome to cardiovascular medicine, where it is all about who did what. Let's say Dr. Smith owns his own EKG machine, does the test right there in his clinic, and reads the results. Bam! He bills the global code, 93,000. But what if a patient goes to the hospital for the tracing and Dr. Smith only reads the results later? In that case, the hospital bills 93,005 for the technical equipment and Dr. Smith bills 93,010 for his professional interpretation. Never, ever code the global 93,000 if your doctor only did half the work.
When we look at diagnostic cardiac catheterizations, I want you to think of these codes as all-inclusive vacation packages. They're comprehensively bundled based on the final catheter placement, so right heart, left heart, or combined. Because they're a package deal, things like vascular access, catheter placement, contrast injections, and hemodynamics, they're already baked right into the base code. Do not unbundle these steps on your exam.
And here is a massive stop sign for echocardiography. A lot of base echo codes, like a complete transthoracic echo, already bundle in spectral and color Doppler. You have got to read your CPT descriptors carefully. If the base code descriptor explicitly includes Doppler, you absolutely cannot build a Doppler code separately. That's considered double dipping, and auditors will catch it.
Which brings us to Rule 4, vascular and neurological services. When coding non-invasive vascular diagnostic studies, like a carotid duplex, you need to watch out for two huge exam triggers. First, complete versus limited. A complete study means every single vessel listed in the code description was evaluated. If even one is missing, you have to drop down to the limited code. Second, these codes demand strict laterality, so your left and right modifiers are going to be your best friends here.
Finally, for neurology and neuromuscular services, think routine EEGs or EMGs, the logic actually circles right back to what we just talked about. These rely heavily on precise time thresholds and component splits, just like those EKG codes. So always verify in the documentation whether you're billing for the technical performance of the test, the physician's professional interpretation, or the whole global service.
Okay, let's wrap this up with our Part 40 cheat sheet. Okay, we've covered a massive amount of crucial ground today. Go ahead and pause this explainer right now to take a quick screenshot of this visual summary. Remember, 1. Always use dual codes for vaccines. 2. Follow the strict infusion hierarchy of chemo, therapeutic, and then hydration. And 3. Master your global, technical, and professional component modifiers. If this breakdown helped you simplify the medicine section, make sure to hit that subscribe button.
So you've mastered the CPT rules for giving a medication, right? But what happens when you code the administration perfectly, only to realize you used the wrong HCPCS code for the physical drug itself, causing the entire claim to get completely denied? Yeah, that's exactly the nightmare we're going to solve next. In Part 41, we're tackling HCPCS Level 2 coding basics, covering J-codes, medical equipment, and strict Medicare guidelines. Until then, I want you to ask yourself, is your clinic currently leaving thousands of dollars on the table just because of simple component unbundling errors? Think about it. I'll see you in the next explainer.